for joining us on today's webinar to discuss our year-long project on revising the Chicago eligible metropolitan area Ryan White Part A standards of care. So first, I would like to begin by introducing myself and our presenters on today's webinar, similar to what Estella just did, but here we have some photos of our presenters. My name is Audra Tobin. I'm the Program Director of Quality and Prevention at CAHISC, also known as Public Health Institute of Metropolitan Chicago. We have our data strategist, Katie Morin, on the webinar today who will be presenting, and we also have Caitlin Hicks, Project Coordinator at PHIMC. Together, we staff PHIMC's Ryan White Quality Management Program at Public Health Institute of Metropolitan Chicago. In addition, joined by Annette Rizzo, a consultant with PHIMC, who had an integral role in designing and implementing the Standards of Care workshops. So we will start with an overview of Ryan White Part A and PHIMC's role serving as a technical assistance provider for CDPH, Chicago Department of Public Health Quality Management Program. We will define a standards of care and explain how it's utilized in this eligible metropolitan area, also known as EMA, and why PHIMC was charged with the task to revise the standards of care. We're going to share why PHIMC decided to host writing workshops as a method for revising the standards of care. We will then review the process for designing the writing workshops to leverage community engagement to ensure all perspectives of those who will be affected by the new standards of care were incorporated within this revision writing process. Afterwards, we will then discuss results of the workshops, and we will also include lessons learned and feedback from participants' evaluations. Finally, we will discuss next steps now that the entire revision process is complete, and of course, we will have time for questions for you all. Next slide, please. Thank you. So the Ryan White HIV/AIDS program provides a comprehensive system of care that includes primary medical care and essential support services for people living with HIV and AIDS who are uninsured or underinsured. The majority of Ryan White HIV/AIDS program funds support primary medical care and essential support services. A smaller but equally critical portion is used to fund technical assistance, clinical training, and the development of innovative models of care. This program serves as an important source of ongoing access to HIV medication that can enable people living with HIV to live close to normal lifespans. Ultimately, Ryan White Part A funds HIV care as a payer of last resort for those living with HIV and AIDS. August 18, 2018 marked the 28th anniversary of the Ryan White Comprehensive AIDS Resource Emergency Act, which is also known as the CARE Act. This is the legislation that created the Ryan White HIV/AIDS program. The program is administered by the U.S. Department of Health and Human Services, as well as Health Resources and Services Administration, and finally, the HIV/AIDS Bureau. The Ryan White HIV/AIDS program is divided into 5 parts. Today, we're talking about Part A, which is the part Chicago Department of Public Health, also known as CDPH. This is the part that, so CDPH receives funding under and provides grant funding for medical and social support services to the EMA, as well as the transitional grant areas, which is also known as the TGA. The EMA and TGAs are population centers that are the most severely affected by the HIV and AIDS epidemic. Next slide, please. So what is Chicago Department of Public Health's role in the Ryan White Part A HIV/AIDS program? CDPH administers the Ryan White Part A program, which provides HIV care services to over 30,000 people living with HIV and AIDS in the Chicago EMA. The Chicago EMA consists of 9 counties. Those counties include Cook, DeKalb, DuPage, Will, Grundy, McHenry, Lake, Kane, and Kendall. Chicago Department of Public Health contracts with over 40 agencies located throughout the entire Chicago EMA to provide core medical and support services to individuals living with HIV and AIDS. In addition, CDPH works collaboratively with the Chicago Area HIV Planning Services Council, which is also known as CAHISC, to determine needs and to set funding priorities. CAHISC consists of 52 members, who are all community members. They're also provider representatives, and clients are individuals living with HIV and AIDS. Each year, CAHISC conducts a needs assessment to identify unmet needs, gaps in services, and barriers to care. The recommendations from the needs assessment process is used to inform the priority setting process, which is also conducted on an annual basis. Next slide, please. So a little bit about Public Health Institute of Metropolitan Chicago, also known as PHIMC. PHIMC has more than 20 years of experience partnering with government and community health organizations. We are affiliated with the National Network of Public Health Institutes. We tackle critical health challenges in partnership with public health departments and other government agencies, as well as community-based organizations, advocacy groups, academic and grant-making institutions, healthcare providers, and associations. Ultimately, PHIMC strives to enhance capacity and promote health equity among public health and healthcare systems in an effort to expand access to services. Next slide, please. So how is PHIMC involved with the Ryan White Part A HIV/AIDS program? PHIMC provides technical assistance to Chicago Department of Public Health, also known as CDPH, in implementing the Ryan White Part A Quality Management Program. Under the Ryan White HIV/AIDS program, every recipient is required to participate in quality management. Quality management is a series of activities that focus on enhancing the quality of HIV care provided to those living with HIV/AIDS and increasing access to services. These efforts focus on how health and social services meet established professional standards and other expectations. As a technical assistance partner, PHIMC was charged with overseeing the process for revising the standards of care for each of the 18 service categories, which includes universal, all of which are funded in the Chicago eligible metropolitan area by CDPH. Next slide, thank you. PHIMC and CDPH put a very strong effort in ensuring the entire revision process for the standards of care was in fact a collaborative effort. So based off our research and findings from other eligible metropolitan area jurisdictions and learning how other jurisdictions revise standards of care, PHIMC served as the advisory role to inform CDPH of best practices for revising the standards of care. Additionally, with the support of CDPH and based off our research, PHIMC designed the process for revising the standards of care, which included facilitating writing workshops as a method of convening content experts and brainstorming newly revised standards of care for all 18 service categories. We later evaluated the effectiveness of the revision process while, of course, keeping CAHISC engaged as advisors throughout the entire process. This was to ensure that the revision process was indeed equitable and inclusive from all possible perspectives. Together, PHIMC and CDPH compiled the results of the writing workshops to draft recommended revised standards of care for all 18 service categories, including universal, which are funded within the Ryan White Part A program of the Chicago EMA. Next slide, please. So before we dive into the entire revision process and how this all went down, we want to give an overview of how the Chicago EMA defines and utilizes standards of care. Standards of care are guidelines that outline the expectations of care around a specific issue or topic. They are typically created by a group of subject matter experts. The standards of care set the standards by which services are monitored, thus supporting quality assurance activities. And just a reminder, quality assurance is the evaluation activities to ensure compliance. Ultimately, standards of care help to ensure that all funded agencies are providing the same basic level of services. This is to ensure that no matter where you are, who you are, or where you live, and where you're receiving Ryan White HIV care, you are to receive at minimal the same quality of service as everyone else living within the Chicago eligible metropolitan area who is receiving the same type of care. Next slide, please. As many of you know, the Chicago EMA already has a standards of care and performance measures document. So the question is, why did we revise them? We revised the standards of care documents to ensure that they align with Chicago EMA's definition of standards of care. We needed to ensure that the standards of care aligned with HRSA's national monitoring standards. We needed to ensure that the standards of care are representative of the current industry norms that exist within our communities or the Chicago EMA. We also want to ensure that the standards of care across all Part A service categories are similar in format and in substance. Essentially, we just wanted to make sure that the standards that were being revised were easy to understand, they were reasonable, and that are attainable by any reader who were to come in contact with this newly revised document. When designing a process for revising the standards of care, PHIMC's primary goal was to ensure varied and diverse perspectives were heard and, most importantly, were at the table during the writing workshops to revise the standards of care. These diverse perspectives included Ryan White Part A providers, clients or individuals who are actively or who have previously received HIV services through the Ryan White Part A program, and we also had CDPH content expert staff who were at the table with us for the writing workshops. Next, PHIMC wanted to ensure everyone had an equitable opportunity to participate. This meant ensuring that those who did not have a prior experience writing standards of care would feel just as capable and welcome to participate as those who did have prior experience revising the standards of care. We accomplished this by providing a very thorough orientation at the writing workshops to all participants, and this was to ensure that everyone had the same basic level of understanding going forward in the revision process. Additionally, PHIMC wanted to make the process of the writing of standards of care as easy as possible. Determining the minimum expectations around a service is important, and let's be honest, it can be very tedious work. When creating standards, there is a balance between fair expectations of agencies regardless of size or resources and accountability in providing acceptable services to clients or those receiving Ryan White Part A services. Finally, PHIMC wanted to ensure a consistent product across all 18 service categories, including universal. At the end of the process, it was expected that all newly revised standards of care for the 18 service categories would be located in one single document. Although each service category would be written by a different group of people during the writing workshop, it was important that the final end product felt consistent across all service categories, and that each group of individuals working to revise the standards of care for a particular service category during the writing workshop understood and could relate to our established goals. Next slide, please. PHIMC also had a couple of challenges to consider when developing the workshop. The first challenge was the limited timeline. Limited time was a challenge in two different ways. Initially, the Chicago EMA wanted the newly revised standards of care finished by February 28, 2019. However, after researching other similarly sized eligible metropolitan area and transitional grant areas, PHIMC found that some areas took over a year to revise standards for all funded service categories. So by holding one-day writing workshops, PHIMC found an approach that would allow us to revise the standards for multiple service categories at a time, thus making the overall timeline much more manageable. But this meant that the amount of time for each service category work group had together to discuss and write the standards of care was limited to only one single day, which leads to our next challenge. If the participants in the writing workshops were only going to meet one time, PHIMC had one opportunity to get these workshops right. Existing EMA standards posed another set of challenges, as many service category standards were written in conjunction with performance measures. Separating the standards from performance measures would allow for more effective product that the Chicago EMA was seeking to obtain. The change to separate the standards of care from the performance measures required a shift in how the standards document would be utilized and perceived, as we found many agencies closely associated existing standards with site visits and monitoring. So next, I'm going to pass the mic to Annette.
Thanks, Audra. So as you all can tell already, we had a lot of parameters, a lot of background information that we were managing, and some design challenges and really thinking through how can we get to the end product that we desire, as Audra has set up through the workshop goals, while at the same time meeting the constraints that she just talked about through the challenges, and then finally ensuring that we're balancing getting to the end product with the experience and contributions from all of our participants. So we decided to take a peek at really how can we use a design cycle to kind of guide how we work through the entire process. So using the workshop goals and challenges as a guide, we set about designing the process we would use. We knew that pilots would be necessary. Remember, we only got one chance to get it right, so we wanted to use some pilots to be certain that each of those workshop days were used to the best advantage. We also wanted to design for continuous improvement in learning alongside checking in to see if participants felt welcomed in bringing their full selves to the workshop tables. Therefore, feedback at every stage would be critical. But if we were going to really value that feedback, we also needed to build in time to adapt our process to each next workshop. So as you can see from this very simple but powerful for our work design process, it was a combination of designing, piloting, gathering feedback, adapting, and working through that cycle. We use the design cycle throughout the standards of care process. We will be sharing more detail in the coming slides about the actual pilots used, the materials and templates, and the feedback and evaluation. But first, let's kick off with a little bit more of the details. So where did we land noticing those constraints? We determined that in order to use both time efficiently but also create a space for participants to contribute meaningfully and inclusively, we needed to accomplish this in one-day sets of workshops, but we needed to constrain the size of those. So we invited between 30 and 50 participants for 4 one-day workshops. Each workshop day had 4 concurrent service categories being workshopped, and each of those 4 concurrent groups had its own designated facilitator. But keeping in mind what Audra mentioned earlier, each of those 4 groups were all using the same format and template, which Caitlin will talk about a little bit later. Next slide, please. So I want to take the next 2 slides and dig in deep into the facilitation principles that we used. And so we're sharing a few of our practices that we employed throughout the process. The first was something called community agreements, which are actually a common inclusive meeting practice. Community agreements make explicit how we will interact with each other through the course of the day. We do this upfront and transparently to create shared understanding and expectations of each other and of those accountable for the meeting space. Oftentimes, community agreements are really meeting agreements, but they're implicit, and some folks feel like they're privy to that information and others aren't. So in order to create the culture we wanted to create the product, we need to make those agreements explicit. We also determined that we needed to have 4 separate groups, that we wanted to have common purpose, an overarching understanding that Audra has just shared with you all. In order to do that, we need to start out all together with all of the 4 concurrent groups in one large group. Then we would separate out into the 4 concurrent groups. Then about the middle of the day, we would pull together all 4 of the concurrent groups again into a big group with the lead facilitator checking in, see what their experience was, see how they thought the work was going, and see if there were any adaptations that needed to be made in the middle of the day. For instance, one day there was a discussion that, hey, you know what, there's just a lot of noise and a lot of conversation, and I know that's good for the process, but we can't hear ourselves talk. Can we kind of spread ourselves out differently? So some of them were really small changes but were impactful for the day, and others were, one of the facilitators would share with me in the middle of the day, I'm having some trouble with my group, and some folks are just talking quite a bit. How can we remedy that? So we were really retooling and adapting and getting that feedback in real time throughout the process. The other thing that made these work groups so successful was the small group size. We did aim to have between 8 and 15 participants. As you can imagine, as a facilitator, the #1 no in design is you never have writing and actually constructing writing happening during a facilitated session. Well, we actually designed these sessions to do just that. So getting above 15 would make it be a little bit complicated, but having less than 8 wouldn't get us that diversity of perspectives that we thought that Audra mentioned earlier. Next slide, please. So few more facilitation principles that we used. We did recruit for and train facilitators for each of the 4 groups to have their own designated facilitator and have one lead facilitator in the room. And the lead facilitator provided support for the facilitators and also was able to step in and help if some of those complications came up. Each facilitator was checking in and monitoring progress, identifying challenges, as well as lead facilitator checking in midway to be certain that the groups were getting what they needed, both to feel that they were inclusive processes themselves for each of the 4 groups, but also that we were on track to get to a content endpoint by the end of the day that we sought. And the other piece that really helped us on the content was, as Audra mentioned earlier, we had content expertise on hand in the room. And that was incredibly helpful, both an in-person individual as well as documentation that Caitlin will talk about in a little bit. And at this point, I think I hand it off to Caitlin.
Thank you, Annette. So I will talk a bit more about the logistics of the workshop. So as was previously mentioned, the work groups were comprised of service providers, CDPH staff, and also clients with experience accessing services. We wanted the final product to be as client-centered as possible, so it was imperative that this process engaged them at every step of the way and that their perspectives really inform the creation of these standards. Participation in the work groups was a significant time commitment, so we were happy to be able to provide stipends for clients that attended to lend their expertise. Because the involvement of multiple stakeholders was so integral to the success of this project, we wanted to ensure that the entire process was inclusive and applicable to all participants. During the registration process, we asked questions related to individuals' association with Ryan White Services, such as whether they're PHIMC staff, CDPH staff, whether they're a provider or other. We also collected demographic information, which included their geographic location, gender, race, ethnicity. All of these questions related to demographics were optional, but PHIMC would utilize this information to assess whether these work groups were comprised of balanced perspectives and diverse representation of those areas mentioned. We also did not want to have access to technology be a barrier for individuals to complete the registration survey, which was the case for a number of clients that participated. In our client recruitment flyer, we included the registration survey link as well as a phone number to contact a PHIMC staff. At that point, a staff member would collect the information over the phone and manually complete the survey. At the workshops, the process for signing in and for welcoming participants and for introductions was also designed with the same intentionality. We did not want to include agency information on the sign-in sheet as one might typically do for meetings, to be inclusive of those without a professional affiliation for Ryan White Services. During the introductions, we provided a prompt for participants to share their name, pronouns, and why they volunteered to participate in revising the standards of care. This way, it left it up to the participants to decide the level of information about their connection to Ryan White Services that they felt was comfortable or relevant to share with the rest of the group. We also took care in handling the required paperwork related to processing stipends. These forms were sent out ahead of time to all attendees, regardless of their registration type, and could be returned at any point throughout the day or mailed after the workshop if that was preferred. Lastly, the meeting location and room setup posed its own unique set of challenges, as Annette alluded to. We needed a space that was large enough for approximately 60 people to meet in the same room as one large group for things like orientation, breakfast and lunch, and also the closing. And the space also had to be conducive to working in small groups with 4 service categories meeting simultaneously. Add in ample parking and the proximity to public transportation, your options are fairly slim when it comes to free or next to free spaces in Chicago. So if you know any options, please, by all means, include them in the chat box. So with that being said, our primary solution involves staggering the tables that were comprised of the individual work groups in one large room. We did find the noise level to be challenging, particularly for engaging some of the more introverted participants, and we received the best feedback when we were able to move 2 out of the 4 groups in individual breakout rooms, but that just wasn't always feasible. So now we'll go over some of the documentation and handouts that the participants received. They were given a folder of materials to guide them through the process of revising the standards of care. We created these materials with a number of goals in mind, some of which Audra mentioned, which were particularly to maximize the participation and to get the best results from these work groups. The folders had a resource guide, which included instructions that outlined what we were providing the participants, expectations for their participation, which was lending their expertise, and a glossary of terms and acronyms they might encounter, and program descriptions and guidelines that were specific to each service category that they were responsible for. This resource guide, along with the orientation provided at the beginning of the session, was intended to really level the playing field. We didn't want the conversations to be dominated by those with more familiarity or experience utilizing existing standards and familiarity with the more technical aspects of the service category, such as the funding streams. So this was also the intent by behind the other handouts, which were created to guide this process for revising. We developed a standardized set of materials that were applicable and used for each service category work group. The handouts were organized into 3 sections: credentials, documentation, and policy and procedure. These sections were based on our initial research that was conducted on the existing Chicago EMA and other EMA standards of care, and we found that the majority of standards fell into these 3 overarching themes or buckets. So within these buckets, we had several topics for consideration. For example, for the credentials section, we included questions relating to facility and agency, direct service staff, supervisory staff, and also would provide an opportunity for the work group to brainstorm if there was anything that wasn't addressed in those sections. These questions were framed to encourage brainstorming within a defined area. For example, one of the questions under credentials said, should staff providing services to clients have a minimum amount of education? Then it would be things like experience, licensure, etc. So our intention for these questions was to really prompt the work group to decide whether having a standard related to that topic was relevant or necessary. Aside from integrating the related HRSA standards, requirements that were specific to that service category into these documents, they were otherwise blank. We wanted to minimize the level of influence that existing EMA standards would have on the revision process, and that was for a number of reasons. The format and recency of the existing standards varied between service categories, and some of the newer service categories that were funded didn't have standards at all. Additionally, many of the service categories had standards of care that were combined with some performance measures, and this would be a shift in how this document would be perceived and utilized. We had copies of the HRSA and existing EMA standards on hand if people wanted to reference those documents, but our process was really created with the intention of drafting these new standards independently of anything else that already existed. By making these templates applicable across the board, we were able to compare information across service categories. So we used the same templates for outpatient ambulatory as we did for food bank, as an example. So to address some of the challenges that Audra mentioned and to maximize the opportunity to achieve our goals, PHIMC borrowed from principles of quality improvement to test our first concept on a small scale. We selected 2 service categories to serve as our pilots, and those were outpatient ambulatory health services and psychosocial support services. CDPH and PHIMC chose these 2 because they were very different, and we would be able to test whether the process and materials developed would work for all service categories. Outpatient ambulatory is a core service category, while psychosocial is a supportive service category, and they provide very different types of services and have very different requirements. Instead of being one full day, we broke these pilots out into 2 half-day sessions, and this allowed for more opportunities to make adjustments and test them in real time. So we use these pilots to test all aspects of the workshop. PHIMC used the registration process to gather information about the recruitment methods we plan to use.
We wanted to know if the recruitment efforts yielded enough providers and clients to get the desired participation. We also asked participants if the registration process was straightforward. We also used participant evaluations, internal check-ins, and actually also had a designated note taker at the pilot workshops to provide feedback about the facilitation, orientation, handouts, and the time spent on the various agenda items. We also used internal meeting debriefs to discuss how to best obtain information through note-taking and how well the notes gathered were useful in developing the final product. So through these two pilots, we learned a lot. Most importantly, the pilots reinforced that people are very passionate about ensuring that clients receive the highest quality of care possible and are dedicated to creating the best standards of care possible. We also learned that the time allotted for creating the standards did not feel sufficient. The process for drafting the standards was time-consuming, and the outpatient ambulatory pilot requested to meet a third time, another third half-day session to get through the remaining sections of the document and finish drafting the standards. And this brought the total meeting time to 9 hours, which was concerning because we had planned for the future workshops to include full-day sessions of approximately 6 hours. We also considered other factors that would lead to this time constraint. We found that it was time-consuming for work groups to flip back and forth between the handouts provided. To aid in creating these standards, we had copies of existing EMA standards and the HRSA standards, and we did not anticipate the degree in which work groups would want to reference the existing to inform the creation of new standards. So this led to a lot more time than expected spent comparing the two documents. We also learned that this process can feel messy and chaotic, and the work groups would sometimes get stuck in the weeds trying to create a finished product. This really just highlighted the importance of having a skilled facilitator to recognize when this is happening and move things along. We learned what to expect from the work group notes as well. We initially had envisioned these work groups would produce nearly complete standards that would just need small tweaks to correct grammar and have consistent writing style. But in reality, we learned the notes were much more of a list of items that the work group wanted to see included in the standards. And the notes would also sometimes include additional questions, thoughts, or summary of discussion points that were confusing to understand if you weren't in the room. Finally, we learned that the language and terminology used was very important to the work groups. Initially, because we're creating these new standards, PHIMC was referring to the existing standards as past standards. This was confusing and problematic for some work group members that pointed out that the existing standards are still in use, and until these are approved and finalized, it's just inaccurate. Additionally, because the handouts were used across service categories, there were instances where terminology was used differently and required clarification. One example of this is screenings and assessments, how those are used, and the timing for those across service categories. So based on the feedback collected from these now 5 pilot workshops, 3 for outpatient ambulatory and 2 for psychosocial services, PHIMC made the following changes. In an effort to address the amount of time needed, we decided to start the full-day workshops an hour earlier than initially planned, which brought the total meeting time to 7 hours. We also tested changes to the facilitation strategies, which included reducing the amount of time spent on orientation and adjusting the focus of the orientation to include an overview of the folder contents, and clarifying that this process can feel chaotic and messy, and that's okay. For the full-day workshops with 4 work groups meeting simultaneously, we needed to rely on volunteer facilitators, some of which were not content experts in the service categories they were facilitating. Because of this, we dedicated time to orienting the facilitators on the process and clarifying the expectations for their role, which is really to keep the work groups productive and on track. We also gave them a cheat sheet with useful information about each service category. An example is if that service category didn't have previous EMA standards, to just let the work group know that. So that's the reason for that is so that they felt comfortable guiding or redirecting these discussions when necessary in a room full of content experts. We also fine-tuned the handouts to incorporate more information about the existing EMA standards that were specific to each service category, and also added a color coding system so that participants could more easily compare but was included in the brainstorming documents and to referencing the materials guide. Another change made was to the structure and guidance for note-taking. We updated the handouts to make it easier to distinguish between solid recommendations for drafted standards from other notes, questions, and discussion points. We also provided more guidance to the designated recorders in those work groups, as well as the facilitator for how to structure their notes in a way that led to more complete thoughts and ideas. And finally, we stopped referring to the existing EMA standards as past EMA standards and clarified other instances where language and terminology led to confusion. These changes proved to be on target, and we did not make any more changes to the documentation after this point for the final workshop. So as I mentioned from the pilot learnings, the work groups were not expected and required to work on our the notes were not as expected and required a lot of work on our end to translate them into functional standards. So how did we do that? First, we wanted to emphasize that the content was developed purely by the work group input and was not dictated by us or CDPH. We did collaborate with CDPH quite a bit and sought their guidance when things seemed unclear from the notes or for how it should be applied as a standard, or if there was additional context needed in order to implement that standard. Notes often reference acronyms or industry-specific guidelines or policies that we would need clarification on. Secondly, at the direction of the outpatient ambulatory work group and the medical case management work group, we consulted with the medical advisory group, which is comprised of clinical providers, to review the drafted standards and confirm the relevancy and accuracy of some of the more technical aspects of these service categories. Following up on the medical advisory group's feedback, we brought their recommended changes back to the work group in areas where the work group and the MAG had differences of opinion and asked the work group to select which option they would like to go with. Throughout the process, the decision-making remained in the hands of the work group, and we engaged them as content experts and wanted to ensure that they remained at the forefront of this process the entire time. Once the standards were drafted, they were sent to the work group for virtual review. As we mentioned, the process could feel super messy at times, and we wanted to ensure we were accurately capturing the work group's original intent. Participants were asked to review each standard and answer whether it accurately reflects the discussions of the work group and if the standard was reasonable, attainable, and reflected industry norms. Finally, we implemented this design cycle process once again for the Universal Standards work group, which came well after the other service categories met, so that we had time to apply our learnings to inform how to structure this work group. There are a few key differences. We narrowed our recruitment strategy to only include those who had participated in a previous work group. This allowed for us to use our time more efficiently and spend less time on orientation. The work groups also didn't start from scratch, working from blank templates as they had previously. Instead, they were given a draft developed by CDPH and PHIMC to review. This is because many of the standards that would be considered universal are dictated by HRSA and therefore required, and also CDPH had a number of items that were important to include as well. Additionally, as we were drafting the other service category standards, we kept a separate log of things that were better suited for universal and applied to all service categories. The work group had already done the work in identifying these, so we wanted to make sure they were incorporated. All in all, we had 32 standards for the universal workshop, and it would have been too much content to go through in addition to having the brainstorming format that we used previously. So instead, we used a different approach that employed the same inclusive facilitation principles, such as community agreements, getting to know each other, clarity on purpose for the day and the process, time and feedback asking for feedback throughout the day and making adaptations as necessary, such as when to meet as a big group or small breakout groups. And this approach started with time for individual review of the drafted standards, and participants were asked to prioritize which were in most need for discussion by the work group, and they used criteria of whether the standard was unclear, lacked information, was inaccurate, or unattainable. So these were similar questions as for the virtual review. Then, starting with the standards identified as the greatest priority, we facilitated a discussion on how to revise these standards to address those concerns. Because of the sheer number of standards, we also structured the virtual review differently. Instead of reviewing all standards, we only included those that underwent significant changes, but we did offer the work group the opportunity to review the full document upon request. And I will hand it back to Audra to talk about the timeline.
Thank you, Caitlin. So revising the standards of care was an 18-month process that began with PHIMC and CDPH conducting research on national HRSA standards of care and standards of care from other jurisdictions. After completing the research phase, we spent July and August developing an overall plan for revising the actual standards of care, which centered on convening and hosting a multi-stakeholder process, which included one-day-long workshops. In September and October, as Caitlin said, we piloted the writing workshops for ambulatory outpatient and psychosocial services. In November, we used what we learned from the pilot workshops to then facilitate all-day writing workshops to revise the remaining 16 service categories. In December and January, PHIMC met with Medical Advisory Group. In March is when PHIMC implemented the Universal Standards of Care, which was the final writing workshop. March is also when we continued to edit the standards of care documents that represented all 18 service categories, including universal, to create a common and clean format on one single document. During April and May, PHIMC disseminated the final edited standards of care document back to the community for a virtual review process. The intention of the virtual review process was to show participants the final edited document that they all worked on to ensure that their recommendations for revisions were in fact included in the final document. We also left room in the virtual review phase for participants to give their feedback and critiques. After obtaining feedback from the community during the virtual review phase, we then incorporated those recommendations into another final document. On June 21st, the very final drafted standards of care document representing all 18 service categories funded within the Chicago EMA was completed and submitted to CDPH. Next slide, please. So the next portion of our webinar will be facilitated by Katie Morin, PHIMC's data strategist.
Hi, everyone, and thank you, Audra, for the kind introduction. I'm going to walk us through the approach PHIMC took to evaluating the revision process, and I'm also going to share a few of the results. So as Audra, Annette, and Caitlin discussed during the workshop design section, by utilizing the design cycle, PHIMC was really employing evaluation throughout this entire process. PHIMC evaluated the outpatient ambulatory and psychosocial pilots to learn best practices for implementation during the full-day workshops. We continued to evaluate the process through the full-day workshops. However, the goal of the overall evaluation shifted away from learning best practices to ensuring that the workshops were really meeting our expectations for workgroup dynamics and participant satisfaction. PHIMC considered both the dynamics and satisfaction evaluation responses as indicators of our equity and inclusion values coming through during the revision process. In total, we collected 101 evaluations across 5 full-day writing workshops. And overall, PHIMC was just beyond pleased with the feedback regarding the workgroup dynamics. 100% of the responses found workgroup members to be interested and committed to the work. Additionally, 98% felt their input was welcomed and appreciated. To me, participants feeling that their input was welcomed and appreciated really was the most important measure of success. And it really is because it indicates that all voices are being included and heard throughout the process. PHIMC was also very pleased with the feedback regarding participant satisfaction. 99% of responses were pleased with the draft standards, and 99% were pleased with the writing workshops and felt their time was well spent. To me, both of these are also an indication that the facilitation, the documentation, and just the overall process for developing standards really led to a very high quality product that's going to serve as the foundation for quality assurance activities in the Chicago EMA. And it it seems that people really felt that way when they were done with writing for the day, when they were done with the work, and when they were leaving that room for the day. In addition to the information PHIMC wanted to know, we also included opportunities for participants to provide open-ended feedback in the evaluation. This gave participants the opportunity to tell PHIMC what they wanted PHIMC to know. We asked 3 broad questions, and on the slide I've included an example of the feedback received. When we asked about what went well, we received 79 responses, and common themes for what went well included collaboration and group dynamics, facilitation and facilitators, and compliments on the overall organization and structure of the day. When we asked about what could have been done better, we received 59 responses. Common themes here included requests for more time, comments about the location of the room and the overall noise just being a little too loud. Also, we received requests to provide documentation beforehand so that people could prep for the day. And we did receive some conflicting feedback regarding the length of the orientation. Some folks thought it was too short and they needed more. Some people thought it was too long, we needed to cut it down. And the last question, open-ended question we asked, was just for any questions, comments, or concerns they wanted to share. And here we received 25 responses. Common themes here included thank yous. We had quite a few people express gratitude for being included in the experience. And then we had compliments on the process. Some other things we saw was just a reiteration of feedback we saw in the prior 2 questions. So people wanted to restate that maybe they needed more time, or restate just how great the facilitation was, things like that. Overall, the feedback PHIMC received through the closed-ended and open-ended questions indicates that the revision process was successful in bringing together and engaging participants, clients, and CDPH in a way that everyone felt capable and welcome to participate. And in the end, I think the Chicago EMA really has a high-quality product that is very representative of the EMA. This slide concludes the evaluation results we have for you today. I'm now going to pass things back to Audra so she can discuss the next steps in the standards of care.
Thank you, Katie. Okay, so as I mentioned previously, on June 21st, the final Standards of Care draft was submitted to Chicago Department of Public Health. Our next steps for this project is to continue collaborating and supporting Chicago Department of Public Health to determine the process for disseminating the Standards of Care to all Ryan White Part A service providers. Ultimately, the goal for this document is to review it regularly to ensure that all standards of care for our Chicago-eligible metropolitan area are relevant, reflective of our industry norms, and are up to date with HRSA standards. Now I'm going to pass the mic to Annette to facilitate some questions for you all.
Hi there. We have a few questions that we would be interested in your feedback and participation. And Caitlin, do you want to take a moment and explain where folks can either raise their hand and or place their questions where Estella has indicated?
Sure, yeah. So if you want to, if you'd like to participate in the dialogue in these questions, you can either raise your hand and Estella will unmute you so that you can speak, or you are more than welcome to type your answers into the comment box. Estella, I'm not seeing the comment box. Oh, there it is. Okay, so yep, we're ready to go.
Okay, and I think we'll just take the questions in order. We're first very curious to know if you have any questions about the information we presented in any category. We realize it's a lot of questions, so let us know if we need to back up on a slide in order to be able to address your question as well.
Just a reminder that your chat box, if you click on the little icon at the bottom, if you hover over your screen, you'll see a little balloon quote. You click on that, it'll open up your chat box.
And then, Estella, if they want to raise their hand, how do they do that to actually speak?
This should be on where you see your, I guess where you see your name on the list. You could raise your hand, and then that'll let me know if you want to ask a question.
Thank you, Estella. Seeing how I'm going to adapt on the fly as we have been doing, seeing how we only have about 7-8 minutes left, I'm going to open it up. We're very interested in the 3 questions that you see in front of you, but if you have other comments or questions that you would like to raise to us, we welcome those as well, either in the chat box or by raising your hands, and Estella will clear you to speak. Estella, I'm just confirmed. Oh, no one has raised their hand.
No, not yet.
Okay. Well, I might do one little push on that, and I had asked Audra and Caitlin and Katie to kind of think about how have they seen equity and inclusion show up in other practices, either within PHIMC or within the various organizations with whom they've worked. And I just think it might be a good time to kind of maybe share a couple of those of how you all have seen equity and inclusion show up within the practices, as well as how you think that what happened here will continue to influence PHI and the work that you're doing.
So Annette, from a perspective of being an employee at PHIMC, what I can say is where I see equity and inclusion kind of showing up in PHIMC is that overall, they're a very transparent organization. And so when it came time for us to start working on our strategic plan, they brought all staff in and brought in professional facilitators and really gave us an opportunity to give them honest and open feedback about the organization, where we wanted it to go, what we saw was like the strengths, weaknesses, challenges we were going to face in doing that.
So really intentionally and proactively providing space for all voices to be heard when actually mapping out the path or the course for the organization.
Yeah, and the facilitators really used some of the techniques you talked about before in terms of, for people who are extroverts, giving them opportunities to just raise their hand and talk in large groups. But then also for those who were introverts, like writing things on Post-its and putting them on walls, or us being in small groups where introverts would maybe feel more comfortable in sharing too, or maybe people who are new to the organization and didn't quite maybe trust that PHIMC really was interested, and that you wouldn't get in trouble if you had a negative opinion about something that was going on.
Thank you for that, Katie.
Of course.
Would any of our participants like to add anything about equity inclusion within their organizations? We're always looking to learn more about other practices. And again, it's open for any other questions or advice that you have for us. And if not, I'm going to pass the baton back to Audra to close us.
Thank you, Annette. So this concludes our webinar on revising the standards of care for today. We thank you so much for your time and attention. And most importantly, we thank you for your service and dedication serving individuals who are living with HIV and AIDS and those who are impacted by HIV and AIDS. The work that you do is not taken lightly, and we appreciate all that you do for our communities. From the bottom of our hearts, thank you. Please remember to complete both evaluations. Your feedback is absolutely critical and crucial and helps us strive for improvements going forward in future webinars. So if you could please take the time to complete those brief evaluations, we would sincerely appreciate it. And we thank you very much once again and wish you all the best of Tuesdays.
Okay, thank you. And I will be following up with an email to include a copy of the slide set as well as links to the post-program surveys and a link to the PHIMC website where you can access all of the QM webinar recordings. So thank you so much.